Well, I'm excited to talk with everyone this morning about a topic I think is important to us as clinicians, but something we don't always talk explicitly about with our learners, and that is uncertainty. And hopefully as we go through, you'll pick up some ideas about ways you can incorporate this into your teaching. So as we go through this brief presentation this morning, we'll try to focus on three things. First, we'll define what diagnostic uncertainty is to start with, to start the conversation. We'll explain the importance of diagnostic uncertainty for learners and contrast that with how experienced clinicians deal with this issue. And then we'll talk about a couple really brief targeted strategies we can use to help our learners become more comfortable with uncertainty as well. So as we get started here, I'm going to ask for just a little bit of audience participation. In the chat function on Zoom, I'd like you to type in whether this is a topic, uncertainty in medicine, that you address with your learners. And if you do already, how do you do that? So I'm going to pause for about 30 seconds here while people type in their answers. Oops. All right. There's a huge rush of people typing in their response. Not so much so far. All right. So actually getting a couple no's, but Helen Grace typed in that this is one of the first things that students need to figure out, and specifically whether a patient is sick or not, what a rash is and how we work through that process. And I would say it's kind of a mixed bag here of those who say that they're addressing this topic and those who are not. So hopefully, again, as we go through, we'll have the opportunity to talk a little bit about why this is something that we probably should be talking about, and give you some ideas about how to do that as we're going through. So let me resume the share screen here real quick. All right. So as we talk about this topic, we need to talk about what diagnostic uncertainty is in order to center the conversation. And before we do that, I'd give you a quote, which is that a diagnosis is a judgment characterized by uncertainty and probabilistic reasoning, and it's seldom definitive at the initial point of care. And I think that sets the stage for where this conversation is going to go. It turns out that finding a unified definition for diagnostic uncertainty is more challenging than you would think. But there was a really nice paper a few years ago that did an extensive literature search, and they proposed that we use the definition of a subjective perception of an inability to provide an accurate explanation of the patient's health problem. So why do we care? Why is this important? We'll talk about why it's important in clinical work, but for our learners and for us as practicing providers, we know that providers or physicians who have difficulty with dealing with uncertainty, there is published literature to say that they have an increased incidence of burnout and dissatisfaction with their jobs. They tend to over-test, and so they'll get more laboratory testing, more imaging studies than physicians who are more comfortable in the face of uncertainty. This leads to increased healthcare expenditures, and in the end, we see more diagnostic errors amongst providers who are struggling with this topic. Experienced clinicians tend to become increasingly comfortable with uncertainty as they get deeper into their practice. And they tend to treat diagnoses, provisional hypotheses or working diagnoses, rather than a definitive diagnosis that you can stick your flag in. And they recognize that clinical reasoning in the face of uncertainty requires an open-minded approach where we take in new information, evaluate that new information, and contextualize it as we're trying to get to that ultimate diagnosis for what's going on with the patient. So I'm going to play a brief video clip to contrast that with what I think a lot of our early learners picture as how diagnoses get made. So this will be about a 1-minute clip.
10 blade.
Hey, stop. Wait, don't cut, okay?
Damn it, DeLuca!
Just stop, okay? I'm sorry, but I found something. I was going over Dr. Weber's history again, and he got a hip replacement 3 years ago in Boston.
Richard Weber is sedated on the table. You need to step away from the sterile field and wait outside.
And you can tell us about it when we're finished.
No. How about now? You listen to me now?
That's it. You're done. Get out. We need to re-sterilize.
No, Bailey, listen to me, okay? Look, you don't need to do the biopsy, all right? His hip replacement was made out of cobalt.
We did a heavy metals test. It came back negative, right?
Not for cobalt. That test is mercury, arsenic, and lead. We wouldn't see that.
Right. And if that hip is deteriorating, Bailey, cobalt poisoning would explain the dementia, the depression, hallucinations, tremors, everything.
Change of plans. We need to draw some blood.
All right, okay, I show that clip. Obviously, this is a clip from Grey's Anatomy, and I didn't just want to put in a clip because I'm a fan of Grey's Anatomy. I actually don't watch the show. But I do think it's obviously over dramatized, but it is an example of, I think, what a lot of our learners come into the clinical realm thinking happens in medicine, that we're going to have this dramatic epiphany, and all of a sudden we're going to have a very clear picture of what the diagnosis is. And yes, there are times when that does happen, maybe not in an OR like that for most of us, but in reality, a lot of the time, there's a lot more gray when we're making a diagnosis. And so that's something that our learners need to learn how to do and learn how to deal with when they're getting into the clinical realm and starting to face the realities of what clinical medicine is. There are a few reasons that our learners struggle with this transition and dealing with uncertainty, not the least of which is that they have limited situation-specific knowledge. And so they just haven't been in those specific circumstances because they haven't been doing this long enough. And along with that, they have fewer relevant clinical experiences. So their depth of experience is a lot more limited. So they just haven't seen the things that the experienced clinician and practitioner has seen. We don't do a great job of teaching this in medical schools, to be frank. And so they come out of the preclinical years, our medical students, again, having that expectation that a lot of times they're going to have that single unified diagnosis right away. And to compound that, our testing strategies, often things like multiple tests, highlight a single best answer, which also leads to the illusion that that's how medicine works. Students also have some uncertainty expressing or verbalizing uncertainty themselves because they don't want to appear weak. And they also fear that they'll look bad in front of their peers, and that if they're expressing uncertainty, that could negatively impact their clinical evaluations as well. And then finally, in a piece that I want to focus on as we do the second half of this presentation, there's a lack of role models who exemplify approaches to uncertainty. So this isn't something that a lot of us talk about explicitly with our learners, whether it's students or residents or fellows. But I would advocate that maybe we change the mindset on that and discuss this a little more explicitly. We know that uncertainty is something that actually is formally called out in some of the standard ways that we assess our learners. So particularly for the residents, there's a great example of this in the pediatric milestones. There's an item specifically linked to them being able to deal with and recognize uncertainty in their practice. And again, if our learners and learners who become practitioners are uncomfortable with this, we know that that's going to have some impact on their job satisfaction, their growth, and their ability to thrive in their practice down the road as well. So how can we help our learners embrace uncertainty? And I'm going to talk about two quick models. I would point out that both of these models are things that you can use with your learners, even if you're not talking about uncertainty. So these are great quick approaches to bedside and clinical teaching that you can use in your day-to-day practice. Both of them are very quick and easy to use too, and kind of help you make sure that you're hitting all the key points of providing feedback, getting your learner to commit, and having some actionable things they can take away from a learning session as well. So the first one is the SNAPS model. We'll go through this one really briefly. But some of you may use this as is not quite as universally used as the 1 minute preceptor, but in SNAPS, the idea is that you ask your student or your learner to summarize the relevant patient history and findings. So that quick 1 or 2 liner about what's going on with the patient. Next, they're supposed to narrow the differential, so give you a list of a couple or a few things that they think could be going on with the patient, and then analyze that differential. So go through the items on the list, what fits well, what doesn't quite fit perfectly. And I would point out that step 2 and step 3 here, both are about the differential diagnoses. Simply talking about a differential diagnosis in and of itself, it implies that there is some uncertainty about what's going on. So I think that's a really key step, regardless of what approach you're using with your students, to actually have them have a differential diagnosis and talk about the items on that list. After they analyze the differential, they can probe the preceptor about uncertainties. So this is where they actually ask you some questions about things that they're not clear about. Then they'll talk about the plan and what they want to do for the patient. And finally, one of the really important parts here is that they are supposed to select some case-related issues for self-study. So what that means is if there are gaps or things that they feel uncomfortable with or feel like is a knowledge gap, they're supposed to do a little bit of directed self-study on that topic. This is a place where you as a preceptor can help them identify the things that they should focus on. That might be asking them to read up on a particular topic and then come back and talk with you about it the next day. The last way to approach this is a modification of something that's been out there for a long time. So in the 90s, the 1 minute preceptor was proposed. And this is a slight variation on that, where we're putting a little bit more focus on uncertainty as we're talking through the items of the 1 minute preceptor. And we'll go through each of these really quickly here. So step 1 in the 1 minute preceptor is asking the students what they think is going on and getting them to commit to whatever it is. And that might be giving you one item, that might be giving you a couple items on a differential diagnosis. And then to pull out the uncertainty aspect of it, you can probe a little bit and ask them, well, how certain are you about that diagnosis? And that gives you an opportunity to talk about the things kind of like in that SNAPS model where we talk about what fits and what doesn't, with a little bit more depth and kind of shed some light on the fact that maybe we don't know for sure, and how are we going to deal with that as we actually manage the patient. Next is to probe. So you might ask the student what aspects of the case make you more or less certain. Is there anything else this could be? And again, this is kind of giving credence to the idea that, maybe we need to keep an open mind and avoid some of those anchoring biases that can really hinder us from seeing the whole picture of what's going on with the patient. And step 3 is to teach and role model. And so again, this is a spot where you as a clinical preceptor come in, and it's an opportunity to, kind of freely express how you feel about the case. If it's a case where there is some uncertainty in your mind too, you might explicitly call that out and say, this is how I'm feeling about the case right now, or I'm feeling a little uneasy about this particular case or this diagnosis because of X. So again, this is an example of modeling in a place where you can show that, uncertainty is something that isn't just something that learners deal with, but something that we deal with in the clinical realm all the time as well. Next, reinforce what was done well. So call out the things that the students did well. And finally, correct mistakes. So if there are things that they had deficiencies in or things that you want to call out, kind of like in that SNAPS model, this is where you can give your learners some take-homes and things to work on their own. So I'll leave you with a quote from Dr. William Osler, who said that medicine is a science of uncertainty and an art of probability. And so uncertainty is something that we have dealt with in medicine forever and forever will. But I hope as we went through this presentation, a couple things that we can take away is that uncertainty is fundamental to what we do in the practice of medicine. Our learners need help understanding how to approach this issue. Uncertainty is something that they will deal with, and if we don't do a good job, it can negatively impact their careers and patient care. And as educators, we can help our learners to become more comfortable with uncertainty as they're gaining competence and confidence in their practice. So I'm going to stop there for my portion of the faculty development and hand it back over to Dr. Simonson.
Thank you. That was really informative. And it is something that I think is hard for us to find ways to weave into our teaching. So I liked that mental construct of adding it into some familiar models that we've known and used for a long time. So thank you. We actually have you up next, Nate, for any education updates that you'd like to provide.
Yeah, absolutely. And I'll be really brief this morning. Just a couple things. We do have an LCME visit coming up. So anyone who's not familiar with LCME, this is the accrediting body that certifies medical schools. So kind of important for UNMC. Creighton went through this about a year ago. We had a mock visit last week, and I think we're in pretty good shape and have the data collected and are ready for the visit. One thing I would make an ask of all of us would be, there was a module that was created in the Canvas websites to essentially certify that you have seen the goals and objectives for the clerkship, you know, some of the policies from UNMC. I think the majority of people have done that, but if you have not, that specifically was designed to hit an LCME requirement. And so getting that finished up helps us make the LCME visitors happy and keep everything on track with getting certification done. If you have any questions about that or the goals and objectives for the clerkship, we are happy to talk with everyone about that as well. Just shoot me an email. One of the other things that has come out of our preparations for the LCME site visit is our patient encounter log. The patient encounter log has been a part of our curriculum across the medical school for a really long time, and it essentially is a list of specific things that the students are supposed to see or do during their clinical rotations. And so on pediatrics, we have a list of 18 items that are called out. As we've gone through the review process, it seems that we really need to have a checkoff on not just some of those key items, but every item on that list to ensure that those are actually being done and documented. And so as we get into the second half of the academic year for our third year students, that actually starts next week for the phase 2 learners. You will see them in the clinical realm with a modification of the old blue card that's been around forever. And essentially it just has some additional items on it. So you may be asked to check them off if you have a patient that has anemia or has a rash or things like that. And that is just a slight change in the way that we've done things with that patient encounter log, but not a new item. So just to give people a heads up, you may see a slight difference as they're coming through. And the last thing I wanted to do is just give a shout out. We had a debriefing session with our third group of students for the academic year. And particularly, I want to give some recognition to the hematology oncology group. We had 3 different faculty members who were called out by the students as they went through in that debriefing session, specifically Dr. Aquasino, Dr. Patel, and Dr. Ralji. And so just wanted to say thank you to the entire HEMONC group for engaging with our students and doing such a great job of teaching. They recognize that and appreciate all the effort that you guys put in. So I will leave it at that, but thanks for the opportunity to speak this morning.
Terrific. Thank you again. And kudos to the HEMONC division for your engagement in teaching. Thank you so much. Next on our agenda, we have Dr. Abrash to give us a culture shaping update.